From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today, we're thrilled to be discussing a new paper just out in JAMA Psychiatry titled Psychedelic Therapy versus Antidepressants for Treatment of Depression in Equal Unblinding Meta-Analysis. We're about to talk to the corresponding author of the paper, Dr. Balázs Szigeti, PhD in the Department of Psychiatry and Behavioral Sciences at the Weill Institute for Neurosciences at the University of California, San Francisco in America. Traditional treatments for depression, like psychotherapies and antidepressants, can be very effective, but not everyone responds. So new treatments are always of interest, and perhaps one new treatment seems to be of so much interest that's always in the news. Of course, this is psychedelic-assisted therapy. There's enormous public enthusiasm for psychedelic treatments, and the question for today is whether the field has moved ahead of the data. To find out more, we're about to talk with the corresponding author of a new paper just published in JAMA Psychiatry on this very topic. So thank you so much for joining us, Dr. Szigeti. And to get us started, psychedelics are always in the news, so let's set the record straight on what they are and what is psychedelic-assisted therapy.
Thank you for the invitation to be on this podcast. So psychedelics is a very broad term, and certainly there are shades of gray in terms of like what is a psychedelic and what is not. So for example, last summer, MDMA, also known as ecstasy, was rejected by the FDA, and there are debates whether MDMA is a psychedelic or not. The point that I want to raise here is just that what is a psychedelic and what is not, it's not black and white, but mostly what most people are referring to are the classic serotonergic psychedelics, drugs such as LSD or psilocybin, which is the active ingredient of magic mushroom, which tends to be the most popular psychedelic treatment option nowadays. Now, in terms of what is psychedelic-assisted therapy, it's exactly what the name says. It is when the patient is going through a classic talk therapy of some form, but the therapy is enhanced with a few sessions of typically large doses of psychedelics. And this is the treatment model that is right now being tested in academia and by industry.
And when we do these studies to test psychedelics or psychedelic-assisted treatment, there's this concept of blinding. And why is blinding perhaps difficult in psychedelic trials, and why does it matter so much in studies like this?
So blinding refers to the fact that we don't tell patients whether they are receiving typically placebo or psychedelic. And this is something which is the cornerstone of modern medical research, the double-blind placebo-controlled research. And by and large, when you don't tell the patients what drug they are getting, they can't figure it out. This concept of blinding works not perfectly, but pretty well, for example, with traditional antidepressants such as SSRIs. The issue with psychedelics is that they induce these very strong and characteristic subjective effects, and that makes them very, very easy to functionally unblind, which is the technical term when patients can figure out when they have been in the active group rather than the placebo group. With psychedelics, typically the effects are these strong visual effects and a changed sense of self and many others that just makes it very easy for patients to realize who's got the real drug and who's got the placebo. And why is this important? It is important because typically what the FDA and other regulatory agencies and scientists typically care about is that what is the specific treatment effect? We know that every treatment has a lot of components to it. So typically what we measure in our trials is something that is called the between arms difference, or also known as the specific treatment effect, which is really the difference between whatever is the effect that we got in the treatment arm minus the effect that we got in the control arm. The issue with psychedelics is that this between arm effect breaks down because now patients can figure out who belong to which group. So the concept of the placebo control breaks down, and this introduces all sorts of biases into the trials that we are trying to account for here.
So would one example be, I'm in a psychedelic study, I don't have a magical experience, so I know I was in a control group, and thus I know I didn't get treatment, so I say I didn't feel better.
Yes, this is a disappointment effect. In the field, the term nocebo effect is gaining popularity. So when patients know that they are not getting the real drug, and this leads to a negative placebo response, a nocebo response. Actually, there's accumulating evidence that because of this fact, or at least we are suspecting that because of this disappointment, the placebo effect is significantly smaller in psychedelic trials relative to most other treatments.
Interesting. So maybe that brings up my next question of what is known about a psychedelic assisted therapy versus traditional antidepressants in these open label studies where blinding matters? So what do we know about this kind of impact?
Typically, when you're conducting a meta-analysis, and there have been a few attempts to compare traditional antidepressants against psychedelics, what people are focusing on is the aforementioned specific treatment effect or between arms effect. And our meta-analysis has the same starting point, but where we are deviating from it is that we are trying to account for this lack of blinding in the psychedelic studies. Where the field is going is that everybody is trying to find a control condition, some sort of an active placebo that mimics the effects of psychedelic close enough that patients are confused again. But with this meta-analysis, we are going another way because what we are saying that psychedelic-assisted therapy is practically always open label, which is the technical term when patients know what they are getting. So what we are saying is that given that practically they're always open label, the fair comparison is when we are comparing it against other open label interventions. So the equal unblinding part of the title of this new paper is that what we are comparing is the within-arm effect of psychedelic-assisted therapy versus open-label traditional antidepressants such as SSRIs and SNRIs. Therefore, both of these treatments now equally benefit from patients doing the treatment and therefore creating more of an apples-to-apples comparison rather than if you would compare the pretend-to-be blind psychedelic trials to the close to blind SSRI trial. The blinding with SSRIs, it's also not perfect, but it's not nearly as broken as with psychedelic-assisted therapy.
That makes sense. We're going to compare apples to apples, open studies to open studies. And in the paper, you and your team report that there's only one head-to-head study of psychedelic-assisted therapy and a traditional antidepressant. This was psilocybin versus escitalopram. What did you learn from the study, and how did it kind of build or expand off the work that you guys are going to do?
So the famous psilocybin versus escitalopram study that was done at Imperial College, and I was working at Imperial, not quite when the trial was running, but soon after. It's a paper that has multiple interpretations. Because what happened there is that the primary outcome was predefined as the quick inventory of depressive symptomology, which is a standard measure of depression. But there were some other depression measures in the trial as well, such as the Hamilton Depression Scale and the BDI.
Okay.
And what happened in this trial is that on the predefined primary outcome, which was the quid, there was no statistically significant difference between psilocybin and escitalopram.
Okay.
However, on all of the secondary outcomes, psilocybin was better than the SSRI.
Oh, my.
And because of that, it led to this weird Twitter debates where you are like a pro-psychedelic person, you focus on the secondary outcomes. And if you're somebody who is maybe not so enthusiastic, then you focused on the predefined outcome, the quids, which came out to be negative. And then one of the issues there, of course, with the study was that there was no data collected on the quality of the blinding. But I think, everybody would acknowledge that it's very, very likely that patients in the psilocybin group knew that they got the psilocybin and patients in the escitalopram knew that they got the SSRI. So this was like a big hot debate when the paper came out. And these discussions definitely helped to the conceptualization of the current paper.
It makes so much sense. We just want to get some answers of how do we compare these things. So let's talk about the three main hypotheses that you and the team had kind of in doing this review, and we'll get to the three main results soon afterwards.
Yeah, so we have a pre-registered hypothesis. I just want to highlight that we did it the proper way. And the first hypothesis that we defined, which is really the most interesting one, is that whether the within-arm efficacy, so the change from baseline to the primary endpoint in the trial, what is the difference between open-label traditional antidepressants and psychedelic-assisted therapy? So this is that equal unblinding comparison that was really the main interest of the trial. But given that we have collected all of this data, we set up two secondary hypotheses as well. And one of them was that is there a difference between open label and formally blinded psychedelic administration, or psychedelic assisted therapy? And here we wanted to confirm the premise of our analysis that there is no difference between open label and blinded psychedelic assisted therapy because practically they are always open label. And the last hypothesis that we had is basically the same, but for traditional antidepressant, is there a difference between open label and blinded SSRI/SNRI administration to again assess the influence of blinding when it comes to these traditional antidepressants?
That makes sense. We look at unblinding of the psychedelics versus antidepressants. We look at the influence of blinding on each individually as second and third hypothesis.
Correct.
Let's quickly talk about the search and how many papers you found and what you screened. We don't have to go into the details, but just so we understand how you guys found all these papers and what you did to get them all.
So we did like a classic meta-analytic search starting really from PubMed, and the usual suspects as keywords like depression, psychedelics, and trial. And then from PubMed, initially we had 619 records. And then myself and one of my co-authors, Hannah Barnett, who went through them one by one, as usual in these cases. And then in the end, when it was all said and done, we have extracted data from 24 papers, 16 of which was these open label trials of traditional antidepressants. And we also found 8 psychedelic trials that met the inclusion criteria.
That's actually a good number of studies. When I read the paper, I wasn't expecting there would be so many of them. So it's impressive you found them. Of the studies that met your criteria, can you give us a sense of, are these large studies? Are they small? What did you make of just their quality overall, roughly?
So the psychedelic-assisted trials, as I said, we got 8 trials that involved 250 patients. And that's not such a large sample size, but of course, this is a novel treatment, so we are expecting this number to be growing quickly as the year's going to go by. And we are already planning to maybe repeat this analysis, let's say 5 years from now, where that number of patients is not going to be 249, but probably closer to 1,000 or maybe even more. When it comes to the open-label traditional antidepressants, of course, they have been around for a long time, and the 18 trials that we have collected involved over 7,900 patients. So we feel like that the effect of open-label traditional antidepressants at this point is pretty much nailed down.
Let's then discuss again your main hypothesis. Number one was looking at what is the influence of open-label psychedelic-assisted treatment versus antidepressants. You have the right question, you did all the review, you had all the data. What did you find?
So before we get into that, I would just like to make a very small detour that I want to introduce this notion of the minimum important difference. And in depression studies, that tends to be around 3 points on the Hamilton scale. And I'm going to talk about a lot of like changes in depression scores. And in all cases, I'm going to refer to points on the 17-item version of the Hamilton depression scale. The minimally important difference on this Hamilton scale is about 3 points. There are different estimates of it in the literature. We are citing them, and whether it's 3, 4, or 5, we can get into the debate. But for the purposes of this paper, we just took it to be 3. What we were really looking for, and what was our predetermined hypothesis, is that psychedelic-assisted therapy is going to be 3 points better than open-label traditional antidepressants, because that's when the difference would feel meaningful. But actually what we have found is that the difference is about 0.3 points. So it is about 10% of this minimally important difference.
So wait, not 3, 0.3.
It is 0.3. Yeah, so we have tested both with the Bayesian model and with the more traditional frequentist meta-analysis model. And in the frequentist model, this was a non-significant result. But even if it would be really that 0.3 difference on the Hamilton scale, that's absolutely noise. That has no, it's not a meaningful difference. Actually, the open-label traditional antidepressants were better with the 0.3 points. But again, that's just noise. Let's not overinterpret that. What we effectively found is that the patient improvement following open-label traditional antidepressant is the same as after psychedelic-assisted therapy. And here I would like to add quickly that we did a lot of robustness analysis of these results. So one thing that we looked at is that each of the SSRI and SNRI medications separately against psychedelic-assisted therapy, but the results are qualitatively always the same. And I would also like to add that several of the psychedelic studies that are included have been on treatment-resistant depression, so when patients fail to respond to prior SSRI treatment. But even if you remove these psychedelic-assisted therapy studies that were on treatment-resistant depression and just include studies that quote-unquote with regular depression, then the results are again qualitatively the same. And I wanted to highlight that because I think that is a fair point that maybe cases in psychedelic-assisted therapy are harder, but we did not find evidence for it. Actually, baseline depression scores were almost exactly the same across these two sets of trials as well. So we feel confident that these results are robust with respect to these variations.
That's a very impressive level of rigor for this type of analysis in it. And for hypothesis 2 and 3, which we were looking at kind of the impact of open label just on psychedelics themselves and antidepressants, let's maybe combine them and talk about just the high-level findings you found there.
Sure. So let's start with the traditional antidepressants. And here, when I look at the frequentist model, actually, I find a statistically significant difference between open label and blinded administration, with the open label administration being better as one would expect it, because now patients know that they are getting a real medication and that introduces all sorts of like positive expectancy effects. However, the mean difference was 1.3 points. And again, that's about half of this minimally important difference, which I find to be very interesting because we are making all of this big deal out of blinding and what sort of biases it can eliminate from the trial. But in the case of SSRIs, it turns out that the difference between open label and blinded administration is really minor. Again, it's less than half of the minimally clinically important difference. I find that surprising. I find this just as surprising as our first hypothesis that psychedelics did not beat open label traditional antidepressants. We have a little follow-up paper on this, so I want to go a little deeper on this, that what is the difference between open label and blinded administration of a given treatment, but not just for SSRIs, but more broadly. It's work in the pipeline, so that's maybe a little bit of a teaser, but I wanted to highlight that. I think, that is really something I was surprised by that. The other hypothesis that we had is respect to the comparison of open label and blinded psychedelics. In sync with our prior hypothesis, what we have found is that there is no difference between the two. In the frequentist framework, the difference was not significant. And in the Bayesian framework, the difference was also about 0.3 points, which confirms that there is no difference between blinded and open label psychedelic administration. They are the same. And again, just to reiterate with SSRIs, formally there was a difference in the frequentist framework, but the magnitude of the difference was surprisingly small.
Those are all fascinating results and may to put them in some context too for clinicians listening or listeners to think about these medications. Do you think your analysis suggests that psychedelics are less effective than perhaps advertised? Or maybe antidepressants are perhaps more effective than they're often portrayed?
I think it's a little bit of both, like, it is somewhere in the middle. And one thing that I would like to highlight, for clarifications, I'm not an MD, I'm a clinical data scientist, but I've worked with a lot of doctors and MDs and therapists. And one thing that, I would like to really get across whenever I have a chance to talk is to appreciate the difference between the within-arm effect and the between arms effect. So the within-arm effect is the change from baseline to the primary endpoint. And what's critical is that that's the patient improvement. However, what we are typically measuring in these trials is the between arms difference, how much better the treatment did relative to placebo. With SSRIs, we tend to be critical because now there has been a lot of papers showing that they are only 2 to 3 points better than placebos. That's the between arm difference, and that's the criticism of SSRIs. And that is true. But what they are forgetting that the within arm effect with traditional antidepressants, it's about 11 points, 12 points, something like that, which is actually very, very meaningful. So I think, what clinicians need to appreciate is this difference between the between arms difference, how much better it is than placebo. That's different from the within arm effect, the patient improvement. That's what the patients and their physicians are going to experience. So just because the between arm effect is small for SSRIs, that does not mean that the patient improvement is small. So I think that's how we can resolve this dilemma that typically, at least in my experience, physicians have better views of traditional antidepressants than most people who are just in the scientific community and not treating patients.
It's a very balanced perspective. And then some proponents for psychedelics on that side may say, well, psychedelics perhaps work through these fundamentally different mechanisms, right? It may be neuroplasticity, a mystical experience, a psychological breakthrough. Does your analysis kind of speak to the mechanism or the clinical effect if these are working in completely different ways?
No, I would not claim that. We just show that the effectiveness is the same, so the within arm effect, that they are so close to each other that maybe suggests that there is a shared mechanism, but I wouldn't go that far. I'll just leave that out there as something very, very speculative, but I don't want to make that claim.
That's a fair answer. And my last main question is, how can we use these impressive results from you and the team to design better studies for psychedelic-assisted therapy?
I think what's critical here, and this is not just true for psychedelics, is that just also disclose the within arm effects. Because the reason why psychedelic has gained so much interest in the scientific community, because we have reported these large between arm effects. But it turns out that the reason why those between arm effects were so impressive is this nocebo effect that we mentioned earlier in the recording, that the placebo response is about half in psychedelic-assisted studies compared to traditional SSRI studies. If you think about it, it's really, really strange that most trials do not even disclose what was the within arm effect, only the between arm effect. But if you do not know what was the within arm effect of your control condition, you don't know that what is the baseline against which the efficacy of the treatment is measured. So I think, a lot of this confusion in the medical literature could be cleaned up if we are much more conscious of distinguishing the within arm effects from the between arm effect. And if trials would not only disclose the between arm effect that they have found, but also the within arm effect of whatever was the control condition in the trial and the within arm effect of the treatment. I think that would clean up a lot of these confusions.
I think you've convinced me, and hopefully all our listeners too, that this is very important. With that, that's our time. Again, I'm John Torous. I've been talking with Dr. Balázs Szigeti about psychedelic therapy versus antidepressants for treatment of depression in equal unblinding meta-analysis. To learn more about this research, you can find a link to the article in this episode's description. This episode is produced by Daniel Musisi at JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.